Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. March is National Colorectal Cancer Awareness Month, and not everyone wants to talk about their colon, but Trinity Health IHA Medical Group colon and rectal surgeon Monica James is here to tell you how regular screening for colon cancer can save lives. So join me in welcoming Dr. James, who sees patients in Clarkston, as well as at our location on the campus of Trinity Health Oakland. Welcome, Dr. James.
Hi, thank you. All right. Thank you everyone for joining. Yes, colorectal cancer is something that's very near and dear to colorectal surgeons' hearts. And I echo what has been said, that a lot of people don't want to talk about their colon and their rectum, and so this is why March is such an important month for us. So the colon, or the large intestine, or the large bowel, as you may have heard it been called, is about 5 to 6 feet in everyone. You can see on this picture here, it's a kind of upside down U or question mark shape. It starts kind of over on your right hip and then comes across your abdomen and goes down to the place where we all know it exits. There are different parts of it, but you can see it's a fairly long organ, spanning across your kind of whole abdomen. And the main function of the colon itself in general is just to help kind of form our stool and to reabsorb the water that we drink so we don't get dehydrated. Colon and rectal cancer is actually fairly common. It's the third most common cancer in the United States, and in men and in women, the second leading cause of cancer-related deaths. And the good news about that, though, is that many times when that cancer is identified early, in its earlier stages, it is very curable with surgery. So, raising awareness about screening and why we get colon cancer and what kind of symptoms to look out for is so important. The majority of colon cancers are random or sporadic. So it's not necessarily related to a genetic defect, or it's not because your mother had colon cancer, or your brother had colon cancer. It's just because of usually a polyp. And we'll talk more about polyps and where they come from. But the majority of colon cancers do start from a polyp and then grow into a cancer over time. Some people do have a higher risk or do develop a colon cancer or a rectal cancer because of a mutation in their DNA. That's an inherited cancer syndrome. And frequently those people have a strong family history of colon and rectal cancer, may know that they already were at high risk because of that, and then may have had genetic testing at some point, or a family member had genetic testing. So the colon, you can see again, same picture, polyps or colon and rectal cancers can form anywhere along that 6-foot long tube. There really has been a strong decrease in colorectal cancer in patients that are older than 50 years old. And again, the majority of that is because we're identifying it and diagnosing it at earlier ages, earlier stage where the cancer is treatable. For a lot of different reasons, and for some reasons which we don't really totally understand, during that same time period, because the patients that were older than 50 were getting screened, patients younger than 50, we've noticed, have had a dramatic increase in the frequency of colorectal cancer. Um, the the death rate from colon and rectal cancers identified in those younger patients less than 55 is also increasing every year. Now, the reason why we're seeing patients that are younger and younger has, I think, a lot of different factors. It may be that because those younger people weren't getting screened in the past, They just were getting diagnosed later or with more advanced or more aggressive cancers. And then you can see the little picture up in the right-hand corner. Colon and rectal cancer is becoming more common, and by 2030 is estimated to be the leading cause of cancer deaths in people under 50. So again, the reasons why we're seeing this, I think in younger people, more frequently now has many different factors, and isn't really understood very well. Um, some people, I think initially were concerned that perhaps that this was related to like genetic changes and colon cancer is getting diagnosed in families that were at risk for cancer, but really the incidences that or the increases that we've seen can't really be explained by that kind of genetic change that quickly. Um, we have some people that sort of estimate that perhaps some of the modifiable life risk factors are playing a role in that. So increasing in morbid obesity, decreasing eating a high fiber diet, less active, and perhaps that is contributing as well. But again, I don't think really anyone can pinpoint one reason exactly why we're seeing this increase in those younger people less than 50. Because of that, though, about 8 years ago, the American Society of Colon and Rectal Surgeons, the American Cancer Society, lowered the risk to start colon cancer screening. So before it was always 50 years old. Everyone starts screening at 50 years old if you're at average risk. And now we've decreased that down to 45 because we're seeing the colon and rectal cancers in that younger population. Now, what does average risk mean? So anytime we say if you're average risk, you should start screening at 45. Average risk means you have no family history of colon or rectal cancer. You don't have a personal family history of a personal or family history of ulcerative colitis or inflammatory bowel disorders like that would increase your risk for colon or rectal cancer. And you don't have any symptoms. So it may be that you are feeling totally fine, but you start having symptoms at 40, or you start noticing some of the symptoms that we'll talk about in a little bit of colon or rectal cancer. And in those cases, then we would recommend that perhaps you have a colonoscopy earlier than age 45. For people that are at increased risk for colon or rectal cancer, they can start much younger than 45. So it would be starting at age 40 or 10 years before the diagnosis of your family member. So if your mother was diagnosed with colon or rectal cancer when she was 50 years old, you would start at 40. If she was 40 years old when she was diagnosed, then you would start screening at 30. So typically that is a first degree relative, so a parent, a sibling, a child, but multiple family members with colon or rectal cancers, and certainly family members that have been diagnosed at those younger ages. We really would recommend you start screening younger. If you have a personal history of polyps, so then you aren't typical average risk, and then you're not really screening anymore. You're having surveillance colonoscopies. Patients that have inflammatory bowel disorders like ulcerative colitis or Crohn's are at increased risk. So they typically will have more aggressive screening. Instead of every 10 years, it may be every 2 years or something like that. Some of those genetic syndromes that I mentioned earlier, those patients are going to start much, much younger to start screening because of their increased risk. And then some patients that have had pelvic radiation or prior abdominal radiation would be at increased risk as well. There are a lot of different options. Colonoscopy being sort of the gold standard. It really is the only way that we're able to simultaneously evaluate your colon and treat you for polyps or prevent you from having a colon cancer at all. And I'll talk a little bit more about what you can expect from a colonoscopy. But we would recommend that you have a colonoscopy, again, starting at age 45 if you're average risk, and then every 10 years if that first colonoscopy that you have is normal. The Cologuard test, I'm sure everyone's seen the commercial with the cute little guy in the right upper corner there, and the catchy song. This is a relatively newer test. It tests for several different things in the stool. So you get a little kit, you send a sample of stool off, and the results come back a few weeks later. The Cologuard test tests for blood in the stool, as well as DNA, which the colorectal cancers or polyps can put off into the stool. And so that's how the test comes back positive. I will say the Cologuard test is a really good test, and it's a very sensitive test. And what that means is it very frequently comes back positive. It only will tell you that it's positive or negative. It won't tell you specifically why it's positive. There is a fairly high false positive rate, meaning that you may have a positive Cologuard test, but that doesn't actually mean that you have colon cancer. And ultimately, it means that you need to have a colonoscopy afterward to evaluate why that test was positive. The Cologuard test, again, is a good test for average risk people that have no symptoms and have no family history. They really didn't study the test in people that are higher risk. So any people that have a family history of colon cancer probably are higher risk and should not have the Cologuard test. Let's say you have a colonoscopy when you're 45 and it's okay, except you have maybe 2 polyps. Well, they didn't study the Cologuard test in people that have had polyps before. So moving forward, you probably shouldn't switch over to the Cologuard test since you had polyps on your first colonoscopy. And then again, any symptoms, frequently the Cologuard test can be positive if you are having diarrhea that day, or if you have chronic diarrhea. If you have hemorrhoids that tend to bleed, then any small amount of blood is going to cause that Cologuard test to be positive. So it's a good test. It's a good option for some average risk people for sure. There are a few other tests worth mentioning. There are some special imaging studies that we can use as an alternative to colonoscopy or Cologuard. Typically, I wouldn't recommend those as like a first line screening test. It's more for patients who have had an attempted colonoscopy and they weren't able to complete it, or they're just not really a candidate for a colonoscopy because they're too ill to undergo sedation, anesthesia, or something like that. So a CT colonography is like a special X-ray study where we have you do a similar prep as you would for a colonoscopy, and then you go through the X-ray machine while they blow up your colon with some barium via an enema. There are also fecal occult blood tests or FIT tests. So your primary care doctor may get a sample in the office and then wipe it on the little card and test to see if there's any occult blood, or meaning not blood that's obviously visible to the eye. And that test you would do every year. Again, much more frequent than what you would do for a colonoscopy. And none of those other options other than the colonoscopy have that therapeutic or that sort of preventative treatment option like the colonoscopy does. So I think, everyone maybe has heard a horror story about the prep for the colonoscopy or the colonoscopy itself or what it really entails. But I'm here to promise you it's really not that bad. The prep the day before the colonoscopy usually entails some time frame where you're drinking only liquids. If you think of the colon as being filled with normally stool and liquid stool and kind of mixing all together, the purpose of the day of the prep is to really clear all that out so that we can see on the inside, so that if you do have any spot polyps, we can find those. So in addition to drinking those liquids that day, you usually will be also drinking some combination of laxative medications. So there's a whole different variety. There are kits that you can get. There are big jugs of pre-mixed prep that you can buy. Some providers will have you buy like Miralax, which is a powder laxative, and mix that into a Gatorade or a Powerade or something like that. There are also pills that you can take for preps. So there are really a lot of options. The choice of which I think will mostly depend on what your provider prefers. Some of your other chronic medical conditions, and then your preference as well. The prep the day before the colonoscopy, I promise, is much worse than the actual procedure itself. The procedure itself is takes about 20 to 60 minutes. You come into the procedure area where you're having your colonoscopy. Um, Typically, you have an IV placed, and either your provider that's doing the colonoscopy or an anesthesiologist will give you some medication into your IV that will help you go to sleep. It's not a full general anesthetic, so you're still breathing on your own. You're having a nice little nap. And then during that time, as you can see in this picture here, um, your provider takes a long, skinny tube that has a light and a camera on the end of it. We go in through the bottom end. We go all the way up across your colon. Like I mentioned, you have about 5 or 6 feet. And sometimes we'll kind of gently puff up your colon with a little bit of air or even water so that we can see around, and then remove any polyps that we find. You are sleeping comfortable during the procedure, sleeping comfortably during the procedure, and any polyps or anything that we find to biopsy or remove is done all at the same time. And then you wake up in the recovery area. Those medications that you get typically wear off very quickly, and then you're feeling back to normal, perhaps a little bit gassy or a little bit bloated for, a couple hours after the procedure. I've mentioned polyps a couple times. What is a polyp? I get that question a lot. So the lining of your colon is very similar to like the lining of the inside of your cheek. It's that very kind of soft pink tissue under normal circumstances. And sometimes some of those cells, because they turn over so quickly, start to clump up and grow and create this little kind of growth on the inner lining of the colon. And that's all that a polyp is, really. The majority of those are totally harmless. They're not cancerous. They don't harbor any cancer cells. And actually, not all of those polyps will turn into a cancer eventually, but some can. And so that's why it's so important to be screened for colon and rectal cancer, and so that we can remove these polyps and they never become anything. Um, Polyps can look differently. So this picture you see on the side here, it kind of looks like a little mushroom where it has like a little stalk on it. Some polyps can be more flat, like they look like a little like piece of carpet or kind of a raised area on the surface of the colon. But they are sort of similar in why they started and what we do about them, which is remove them. The majority of time, these polyps don't have any symptoms. They're typically quite small. I think it looks bigger in the picture, but they can be as small as like a little pen dot. They can and then grow bigger over time into the size of like a blueberry or a grape or a walnut, all of which can usually be safely removed with the colonoscopy. There are a lot of different ways that we can remove polyps during the colonoscopy. Through the long skinny tube that makes up the scope, we can put a little grasper in, so a little kind of chomper thing that can remove the colon polyps. We can use the picture that you see here, something called a snare, which is really like a little lasso where we kind of lasso the polyps off. And the inside of your colon doesn't have pain receptors like you would feel like on your skin. So it's not a painful procedure. And on top of that, you're asleep for the colonoscopy at any rate. So removing those polyps is not something that's going to cause you to have a lot of pain or anything like that. Typically, we remove those polyps. We kind of note where they were on the inside of the colon, and then we send them off to the lab. And the pathologist looks at them under a microscope and tells us what kind of polyp they are. You may get a pathology report afterward, which I think is good. You know, the MyChart era is great. It's nice for patients to feel like they have a little bit more say in their healthcare, but I do think sometimes people get that pathology report and it like freaks you out because you don't know really what is going on. So a lot of times these polyps will come back as what we call adenomas or adenomatous tissue. That's kind of a normal run-of-the-mill polyp. Um, Other types of polyps we see sessile serrated polyp, tubulovillus polyp. All of those things are kind of big words that literally just mean polyp. None of those are precancerous. They are just polyps that can eventually become a cancer if we leave them alone for too long. Now, some polyps can start to have some dysplasia. That's what precancerous cells would look like. And the pathologist will always write that in the report. And then eventually down the road, they grow larger and they can become cancerous. So the take-home message about all of the screening is that really you shouldn't delay it. It's kind of the prep for the colonoscopy the day before the prep part. It's not fun. It's not a fun experience. I wish it were easier, but it's really worth it to prevent colon cancers down the road. And again, if you are average risk and you have no symptoms, that's, starting at 45. But if you do notice anything, so rectal bleeding, not normal, changes in your bowel habits. So if before you used to be very regular, have no issues, and all of a sudden you're noticing a dramatic change where you're having some severe constipation, if you're feeling bloated, if you're having an unexplained weight loss, those are things that maybe you should talk to your primary care doctor about, and perhaps you should have some colon cancer screening younger. So, all right, I'm going to switch gears then and go into colon and rectal cancer. Oftentimes, colorectal cancer does not have any symptoms. And that's why it's so important to preface all that conversation with the talking about polyps and talking about colon cancer screening, because we can prevent any of these cancers from eventually forming. But if you have a colon cancer or a rectal cancer that doesn't have any symptoms, it may be found on a colonoscopy. It could also be found incidentally, or like, for example, you had a kidney stone, so you had a CT scan, and they may see a colon or rectal cancer there. Another reason to sometimes be diagnosed would be abnormal lab testing. So you have a colon or rectal cancer and it's sort of very slowly dripping off little bits of blood. And so perhaps you get some labs drawn from your primary care doctor and they find that you have some anemia or you're, losing blood somewhere and they don't know why. You can see on the picture here, as the cancer starts to grow a little bit, then you may get some of those local symptoms that we just talked about. So the cancer forms on the inside lining of the colon there. And as it gets bigger, it may start to narrow the area of the colon that the stool has to move through. And so for that reason, you may start to notice changes in your bowels. Perhaps you're having more constipation than you were having before. As it starts to grow and your colon starts to be slightly blocked, you can get some discomfort, some bloating maybe, some nausea or vomiting. And it may ultimately grow so much that it starts to like block off the stool and the gas that can get through that piece of the colon. Associated with that, if you're having a lot of unexplained weight loss or loss of appetite or just extreme fatigue, those could be some of those systemic symptoms of a colon or rectal cancer. We talked a little bit about like anemia or sometimes those tumors as they start to grow, they can shed off a little bit of blood or even start to bleed a lot. And then you may notice some rectal bleeding. They can also cause some infections, or the tumor itself can grow so large that it may rupture. So some of those more urgent issues would be reasons for you to rush to the emergency department, and that's how your provider may find out that you have colon or rectal cancers in the emergency room. Invasive colorectal cancer diagnosis is typically going to start with some sort of tissue diagnosis. Most often that's a biopsy from a colonoscopy. So either you're having a screening colonoscopy, or they, like we just talked about, they found something abnormal on a CT scan, or they were wondering why you were anemic. You go for a colonoscopy, we find the tumor, and we take biopsies of it. Those cancers or tumors are usually much larger than polyps. They typically look different than polyps look as they start to grow bigger over time, and are usually much too large to try to remove through that long skinny scope. So biopsies are easy to obtain that way, so that we can send those off to the pathologist, and the pathologist can confirm what we are suspecting. The tumors also can be tested for special markers to help kind of guide your treatment team with your treatment. After the tissue diagnosis, typically your surgeon or your primary care doctor or someone will send you off for some more testing. So that part of that will be imaging, a CT scan, special kind of X-ray tests of the chest, abdomen, and pelvis to see if we can sort of figure out what the extent of the disease is. For rectal cancer specifically, it also likely will involve an MRI of the pelvis to see kind of how involved that tumor is, and if any of the adjacent areas of lymph nodes look abnormal. Typically, you'll also be sent for some lab tests, maybe looking for anemia, maybe looking at your kind of general kidney and liver function, as well as tumor markers. The tumor marker for colon and rectal cancer is called a CEA level. And then typically after all that's done, you'll meet with sort of a comprehensive team of specialists, sort of depending on what we're thinking that your treatment algorithm will be, if it will be surgery first, if it will be some other treatment first and then surgery, or depending on the stage. So the staging of really any cancer is describing the extent of the cancer in the body. And specifically the colon and rectum, the tumor, any cancer starts on the innermost lining, so sort of on the mucosal surface or the inner lining, and then starts to spread deeper into the colon. And if left untreated, then it can start spreading through the wall of the colon itself, actually, into other adjacent structures. And little cancer cells can start to spread or break off and travel through the lymph system or through your bloodstream into nearby lymph nodes or into other organs, particularly the liver and the lungs for the colon and rectum. Why does staging matter? Staging matters because it does affect the survival of colon and rectal cancer. So if you have an early stage tumor, stage 1 or 2, that's diagnosed and treated, 90% of the time, 5 years from now, you'll be alive and doing well. After the cancer has started to spread to the adjacent lymph nodes, or stage 3 colon or rectal cancer, then the chance, the 5-year survival rate drops down just a little bit to about 70%. And then after the colon cancer or rectal cancer has started to spread to other organs, so it's spread from the cancer itself at the colon into the lymph nodes and then onto the liver or onto the lungs, then the 5-year survival rate starts to drop down to more like 10 to 12%. So, that's not 0%. That's still, 1 in 10 people that has treatable disease and is doing well at 5 years, but different obviously than those early stage cancers. The treatment for colon and rectal cancer is really going to depend on what stage you are at the time of diagnosis, meaning is the tumor early stage or just in the colon or the rectum itself, or has it started to spread to the lymph nodes or other organs, and is that metastatic? The kind of cutoff or there is usually the earlier stage localized disease is treated with a surgery first option. So surgery to remove that either that part of the colon where the tumor is or the rectum. Um, some rectal tumors, if they're very, very early stage, can also be removed through the anus, so through the bottom end, and we don't have to go in and through your belly and remove your whole rectum. Um, and then in some cases, after surgery, you may be treated with some adjuvant or post-operative chemotherapy for stage 3 cancers or for some stage 2 cancers. Um, for tumors that at the time of diagnosis, your cancer has already spread to the lymph nodes or other organs, or you have metastatic disease, typically you're going to get some additional testing on the biopsy results, and then you're going to get some form of systemic therapy up front. So chemotherapy, sometimes some additional targeted therapies or immunotherapies, and then as well as radiation for rectal cancer. And then a lot of times it really is a team approach of starting you off on that therapy, having the cancer doctor and the radiation doctor and the surgeon all working together to evaluate how you're responding to that, and then eventually determining if you're a surgical candidate down the road. Um, the surgeries for the colon and the rectum are the same, removing that part of the colon or the rectum. But then there are other options for removing those tumors that have started to spread to other organs. So either ablation or removing pieces of the liver or the lungs. Colectomy is the surgery that we would perform to remove that piece of the colon when you have a colon cancer. Typically, we're going to remove a segment of the colon. And the reason that we can't just remove the little piece that has the colon in it, that has the cancer in it, is that we want to involve that piece of cancer as well as 5 centimeter margins on either side to make sure that we've gotten negative margins on that tumor. And we also want to make sure that we get all the lymph nodes that sort of live in that area so that the pathologist can look at those lymph nodes afterwards and make sure that there haven't been any tumor spread to those lymph nodes. Typically, those two pieces of the colon can be put back together at the end of surgery. The only situation where that may not be the case is if it's an emergency or if you have one of those complications from a colon or rectal cancer that's become a little bit more advanced. In the case of colorectal cancer, we typically don't actually know the status of the lymph nodes until after surgery. So we can sometimes tell based on your CT scan if some of the lymph nodes look a little bit bigger than normal, but we can't tell whether or not there are tumor cells in them until the pathologist looks at them at the end of surgery. So that's why some people may have surgery up front. We send the tissue off to the pathologist. We identify that the tumor has spread to the lymph nodes, and then the patients will get some chemotherapy after surgery. If you have a tumor in your rectum, the rectum is the kind of last about 6 to 8 inches of your colon. It's more of the storage vessel at the bottom there. You're going to have what's called a proctectomy, which basically just means surgery to remove the rectum. And then again, we take all the fatty tissue around the rectum and all those lymph nodes that live around the rectum so that the pathologist can look at the specimen and determine the stage. And then again, the majority of time, the colon can be brought down and the two ends can be brought together so that you can continue to use the bathroom as normally. There are some people who cannot have a reconnection at the time of their surgery. There are a lot of different reasons for that. It may be that it's an emergency and you have an obstruction, or the tumor has perforated or ruptured and you're very sick. It may be that the tumor within the rectum has invaded the sphincter muscles, those muscles that help you hold your stool in. And so we have to remove that so we can't safely reconnect things. But most of the time, if that's not the case with where we're removing the anus, the stoma or the colostomy can be a temporary thing. It can be reversed in the future. In those cases, we'll remove the cancer, remove the segment of the colon or the rectum that have that tumor in it, and then bring up the stoma, bring up the colon through the abdominal wall, so that stool exits through that and into a bag that is attached to your abdominal wall. There's been a lot of great advances in minimally invasive surgery over the past several decades. So a good majority of colorectal surgeons and general surgeons that are taking care of patients that have colon and rectal cancers are doing so minimally invasively now. That means either laparoscopically, which you can see the picture in the upper left-hand corner here, where you have small little port sites. The surgeon stands at the side of your bed and uses long, skinny instruments where we go in through your belly and do the surgery that way, or robotically. That picture in the middle there where, again, you have small little poke holes on your belly. We blow up your belly with some air, and then we go in and control the robotic arms at the console where we're sitting. And both laparoscopic and robotic surgery have been shown to be very safe. There are equivalent oncologic outcomes, meaning we're just as likely to cure your cancer if we're doing it minimally invasively as if we were doing it open surgery with a big long incision down your belly. But the difference is that because you have smaller incisions, patients tend to heal more quickly. You have much less postoperative pain. Your bowel function returns to normally more quickly. You have a shorter hospital stay. You're less likely to get a hernia. So for a lot of reasons, really, minimally invasive surgery is a really great thing for both surgeons and for patients. You can see that picture right at the bottom hand corner there. That's what those either laparoscopic or robotic port sites can look like a few weeks after surgery. So just small little incisions. They sometimes have like stitches or skin glue or, and then that goes away and you just have some small little scars there. Chemotherapy, either after surgery or for patients that have stage 4 metastatic disease and are getting chemotherapy free up front, is typically a medication that's given in through an IV. Sometimes patients will also have kind of a more long-term port put in that goes into a big IV so you don't have to get stuck with a needle every time you go for treatment. The medication kind of travels through the bloodstream and kills both cancer cells and healthy cells. And that damaging to the healthy cells is unfortunately the typical culprit for a lot of the side effects of the chemotherapy, like fatigue, hair loss, diarrhea, nausea, vomiting, stuff like that. There are a lot of different regimens meaning some combination of several chemotherapy agents that the oncologist will give you to sort of target the best colon cancer tumors. And again, chemotherapy may be recommended for some stage 2 tumors, but definitely for stage 3, meaning the tumor has spread to the lymph nodes, and to stage 4, meaning that the tumor has spread to other areas of the body. Radiation therapy is also commonly used for rectal cancer, particularly for rectal cancer because it lowers the recurrence risk or the chance of the tumor coming back in the future. The most common type that is applied is called external beam radiation, meaning you kind of lay in like a tube and the machine delivers the radiation kind of from the outside of your body in, and it is carried to the cancer site. There are different regimens there. It's much more complicated even than I think I'm making it. But there are some sort of long course sessions where you get therapy over, 5 to 10 weeks. There are some short course sessions where you give a higher dose over 5 sessions, which would be over 5 days. But all that is a part of the decision that the whole, group, the surgeon and the oncologist and the radiation doctor make in your treatment algorithm. I think I kind of mentioned briefly, there are some newer targeted drugs that have been shown to be really beneficial, mostly in metastatic cancers, so cancers that have already spread. But at the time of tissue biopsy, the pathologist will test for some of these special markers, and then we can use either drugs that are going to target a specific feature of the cell, so they may attack specific receptors. They may stop overactive proteins from sending growth signals. They may stop the tumor from growing new blood vessels, or they may kind of target your own personal immune system to help your body actually fight and destroy cancer cells. So I think that's a really exciting realm that's really been in development, and I'm sure much, much more to come on that. So after all that, how do you reduce your own personal risk for colon and rectal cancer? I can't say it enough. Get screened. Start at age 45 or younger if you have high risk factors or if you have any symptoms. Exercising and maintaining a normal body weight. Eating a healthy diet with plenty of fruits and vegetables and high fiber foods. Fiber foods being like raw vegetables, grains, oats, things like that are really, really good for your colon. They kind of help keep your stool nice and regular. They help pull toxins out of your stool, and they are really good for, bowel function and for hemorrhoids and everything. So avoiding foods high in fat can also reduce your risk in colon and rectal cancer. And then stop smoking. Don't smoke if you don't smoke, and drink alcohol in moderation. If you are diagnosed with colorectal cancer, don't panic. We We'll create a comprehensive approach to your treatment. A lot of people are involved in that, and there are a lot of extensive support resources for anyone that gets diagnosed, both right at the time of diagnosis, throughout the course of your treatment and surgery, and then in surveillance after you are after you're cured from cancer. Then you get put into a surveillance program where we keep a close eye on you and make sure that you're doing well and that the cancer never comes back. And that is all that I have.
Okay, fantastic. Thank you, Dr. James.
Yeah.
We will move into the Q&A portion of our presentation. So if you have a question, many of you have already found your way to the Q&A feature, and we have several questions to start with. But if you do have a question, please feel free to drop it in there at any point, and we will try to knock down as many of these questions as we can. So are you ready to get started?
Yeah.
Okay. Do hemorrhoids contribute to colon cancer?
They do not. Hemorrhoids are a normal kind of piece of everyone's anatomy. So everyone has hemorrhoids to some extent. Hemorrhoids are kind of tissue and blood vessels that lives around our anus, and under normal circumstances just kind of helps us with our continence or with kind of sensing if we're having a gas or if we're having a stool. And they can get bigger over time. They can bleed. They can be painful and irritating, but they don't typically become a cancer or cause a cancer. That being said, a lot of times hemorrhoids are, I think, a scapegoat for other problems, meaning like perhaps a patient has like an abscess, or they have actually maybe an anal cancer, but everyone's like, oh, it's just your hemorrhoids, it's just your hemorrhoids. So I think my take home message is like, yes, everyone has hemorrhoids, but if you are having a change in your symptoms of hemorrhoids or something doesn't feel right or it's super painful, then perhaps ask to see a specialist because it's not always like, oh, just hemorrhoids and do a sitz bath.
Okay. Couple questions about polyps. So one is, can you talk about or re-describe what are precancerous polyps? And can you talk about the difference between polyps and ulcers?
Yeah, so a polyp in general is just like we talked about, right? Like clusters of tissue. It's totally benign. It's not precancerous. But as that clump of little cells starts to grow a little bit bigger, some of the cells can start to change and start to get some like genetic mutations in them, and then they can become precancerous. So a straight up normal tubular adenoma, tubulovillus adenoma, whatever your pathology report says, polyp, not cancer. A tubular adenoma with pre-cancer would be with like dysplasia or precancer cells. And then over time, the precancer cells or the dysplasia can convert into an adenocarcinoma. Um, and then ulcers are just sort of a different entity. Like a polyp is like a clumping up of cells, like a growth. An ulcer is more of like an irritated area where the mucosa starts to kind of slough away and it becomes irritated and it's like a shallow or sometimes larger kind of crater on the colon. And those ulcers are typically more common from like an inflammatory bowel disease, like ulcerative colitis or Crohn's, or like a C. diff colitis or some other irritation in the colon. They can um, they can and should typically be biopsied to make sure that there isn't any malignancy there, though, I should say.
Okay. There are a few questions about diverticulitis.
Mhm.
Does that increase your risk of colon cancer? And there's one other one. It looks like, I'm sorry, I was just gonna, so it looks like polyps were found, but they were removed and they have ongoing colonoscopies. So can you talk a little bit about the risk and how diverticulitis fits into that?
Yeah. Okay, so while we're on the polyp topic, I'll start there just quickly. So I should have mentioned that. I can't believe I totally skipped them. That totally slipped my mind. So if you have a colonoscopy and you have polyps, normally you'll get put into like a more aggressive screening regimen than the normal population. And polyps are very, very common. So probably 1 in 5 or even 1 in 4 people will have polyps on a routine screening colonoscopy. And so instead of having a colonoscopy every 10 years, you maybe are having a colonoscopy every 5 years or every 3 years, depending on how many polyps you had and what kind they were. Um, and if you have a colonoscopy and you have polyps and they're removed, then that's great. You don't have to worry about them. It's not like you need to worry about that particular polyp growing into a cancer because it's been removed. But we do those more frequent colonoscopies to make sure that no new ones have grown up in the meantime. I think that answered the question. And then diverticular disease, so diverticulosis, diverticulitis, is a totally separate entity from colon and rectal cancer. So diverticulosis means that on the colon itself, instead of being like a smooth, long tube, there you get little spots that kind of pouch out on the sides of the colon. So instead of a smooth tube, the colon looks more like a pickle. And those little pouches that kind of form on the side of the colon can cause problems over time. They can bleed, they can get infected and cause the diverticulitis, where your colon gets really irritated. Sometimes those little pockets can even rupture or burst, and then you end up in the emergency department and sometimes in an emergency surgery. But just having diverticulosis or even having diverticulitis doesn't necessarily increase your risk for colon cancer or doesn't mean you have colon cancer. Now, that being said, everyone that we see that has diverticulitis, we always want to make sure that they do have a screening colonoscopy at some point after they've recovered from their episode of diverticulitis. And that's because sometimes, very, very rarely, we meet you in the emergency department, you have diverticulitis, you get treated with some antibiotics and you get better and everything looks great. But maybe 1% of the time, what we thought was actually diverticulitis truly was a colon cancer. And so for that reason, people that have had diverticulitis in the past should get screened or should have a colonoscopy at some point to make sure that it was truly diverticulitis.
Okay. So there's a question about how to know when you should be screened a little bit earlier than 45. So this person has a history of hemorrhoids and fissures due to hard stools. To alleviate it, they take magnesium. However, that means that there's often blood in the stool or that they have diarrhea. So they're only 41, no family history of colon cancer. However, since it's becoming a disease that affects younger people, they're wondering about their risk. And it's hard to tell if symptoms are just sort of the status quo or it could be something else.
Yeah, yeah. And um, so in that situation, I would say, technically, because you're having symptoms, it wouldn't be like a screening colonoscopy, it would be more, diagnostic. So, um, if you've had hemorrhoids and fissures, and you're having frequent blood in your stool, you probably should have a colonoscopy sooner rather than later. And not just for colon cancer screening either, to make sure that there's no other sources of bleeding, to make sure that there isn't some source of like inflammatory bowel disease or anything like that. Um, and your provider may be able to even treat your hemorrhoids at the time of your colonoscopy. Um, but I think, truly like the screening, definition of a colonoscopy would be really for like someone who's 45 and has no symptoms at all. But I'm on the same page. Even without a family history, I would recommend that you get a colonoscopy.
So their primary care doctor said that they thought this would be an out-of-pocket cost, but like you're saying, if it's a diagnostic reason, then that should be
Should
covered
be
a
still
different
covered.
way. Yeah. Okay. So
Yeah.
it should be covered in a different way because it's not a regular
Yeah.
screening. Okay. And that's interesting because I'm sure there are so many just different bowel issues that people treat just over the counter and kind of just think that's just how my body works.
Yeah.
I guess
Yeah.
it's important to bring that up and be aware of it as you kind of get close to that screening age. Does that make sense?
Absolutely. I think too, like just me personally and a lot of my colleagues, historically we used to sort of just like, oh, you're having blood in your stool, but you're 30, we'll treat you for hemorrhoids for years and years and years. And because we're seeing these cancers in younger people now, our threshold for recommending a colonoscopy is just getting lower and lower because it really is such a safe, and pretty quick procedure to go through with such a high benefit and pretty low risk.
Okay. And this person is asking their husband's family has a history of colon cancer. So they're wondering what age their children should get a screening done. And I'm assuming that's absent of any symptoms.
Yeah, yeah. So it would be either at age 40, or 10 years younger than the youngest diagnosis. So if your husband's father had colon cancer when he was 40, then, your husband and your husband's children should be screened at 30. So whichever comes first.
Okay. And there are several questions about the prep. Um, this one sounds awful to me. The person prepped, but then we're told that it wasn't cleaned out enough. Oh, I can't imagine that going through
Yeah.
that and then being told that. Um,
Yeah.
so they're wondering if there like a 24 pill, 12 pills the day before and 12 the day of? Is that a possible prep?
Yeah, that's it's called Sutab. Um, and it's exactly like you said, it's what we call a split dose prep. So you still are drinking just liquids. The clear liquid diet thing doesn't change. But then the night of before the colonoscopy, you're taking 12 pills. And then the morning of very early, you're taking 12 pills. And for patients that I've had that have used the Sutab prep, it works just as well. It is a whole ton of pills to take. I won't belittle that, but yeah, that works just as well.
And I'm sure they're not like the teeny tiny pills, I can imagine.
Right.
Probably decent
They're pretty big.
size. But there are several people who are saying that the prep sounds hard. One person says she has chronic GERD and has a lot of trouble with skipping food and then drinking a lot of fluid.
Mm-hmm.
So it gives
Yeah.
rise to intense acid reflux and chronic uncontrolled coughing. So could the pills possibly be an option for her?
Yeah, they may be better. I mean, I think there really isn't a way to avoid the no food thing. Uh, so I think that may be hard at any rate, but your provider could maybe call in some anti-nausea medication, or you could take some, antacid medication that day of. And then the pill prep could be better. Some of the other prescription preps are much less volume of liquid as well. So historically, people used to use what's called go lightly. Like you would go to the pharmacy and pick up this literal like 4 liter jug of liquid that you would have to drink. And that's sort of a torture device that I don't know anyone that really recommends that or uses that routinely anymore. So a lot of the newer ones are much smaller liquids and they're easier to take down.
Okay. So we talked about the early side or the early age of having a colonoscopy. There are a couple questions on when you should stop having colonoscopies. So this person said they failed a colonoscopy and then a CT scan, had their sigmoid colon removed 3 years ago. They're 77, and the guidelines say they no longer need a colonoscopy, but have had polyps removed in the past. Would you recommend that they continue having colonoscopies?
So, um, so, and I guess it's hard for me to tell, but it was a cancer surgery. It wasn't a cancer surgery. It sounds like, I guess maybe
He, yeah, he said he failed the colonoscopy and a CT scan and had his sigmoid colon removed.
okay. So perhaps like from diverticulitis or something in the past, that area of the colon had become narrowed. And so that does happen sometimes. We try to do the colonoscopy, but for some anatomic reason, we can't safely advance the scope through that piece of the colon to evaluate the other areas. Um, so there used to be sort of like a hard line cut off for routine screening colonoscopies to stop at 75. Like that's when Medicare would stop paying for them. And that's not necessarily the case anymore. So if we're talking about purely screening, so you're just having colonoscopy, you've never had polyps before, you're just having a screening, somewhere around the ages of 75 to 85, we talk about, what are your other medical comorbidities? How difficult for you is it to do the prep? And should you continue to do screening colonoscopies? So I think that like idea of at this age, we cut off screening, it doesn't exist anymore. Um, and then I think it's a totally different situation for people that have had polyps because in that case, you're not really truly screening anymore. Because you've proven that your body tends to grow polyps. So you're more of like a surveillance, like making sure you haven't grown any new polyps. So for you, if I can't remember, I'm sorry if you said they were 71 or 75 or something. I probably would recommend one more colonoscopy at least, as long as you're relatively healthy otherwise, and your doctor thinks that you could tolerate having the sedation and everything like that.
Okay. And then we have a couple of questions about different types of cancer. So the first one is the person is asking, is colorectal cancer in the same family of cancers as breast cancer? And then another person is saying that she found out she's a carrier of Lynch syndrome mutation, and she's a 2-time breast cancer survivor. She's
Mhm.
told she needs a colonoscopy more often since she's at higher risk for all cancers. And she's wondering how often is often. She is 68 years old.
Yeah. So the Lynch question, yes. Typically, patients that have true Lynch syndrome or carry one of the genes for Lynch should have a colonoscopy every 2 years. Um, Typically, we start that really early, so even at age 25. But yeah, if you've had breast cancer already, twice, then yes, screening colonoscopy I would recommend every 2 years. And then breast cancer and colon rectal cancers um, co come from sort of different cell lines. So like the tissue that makes up the breast is a little bit different than the tissue that kind of lines the inside of the colon. And so for that reasons, like the type of cancer that grows are a little bit different. Um, there are some genetic syndromes like that Lynch that we just talked about, where you are at higher risk for both breast cancer and colon and rectal cancer. And so sometimes those patients will have, more aggressive screening regimens, or if they've had a history of breast cancer or endometrial cancer, things like that, then they would be put into a more rigorous colonoscopy regimen.
Okay. And there are several people who say that polyps were found on a colonoscopy. So whether they're found and they're not found to be cancerous, or they're found on one colonoscopy but not on a second one a couple years later, does that change how often you should go if you have a polyp, period? Or does it have to be something that's like more serious?
Yes. So, um, I think most providers now are taking an individualized approach to deciding when you should have another colonoscopy if you have polyps. So we're looking at how many polyps did you have? What type of polyp were they? Did you have any dysplasia or precancer? And how many colonoscopies have you had in the past? So, for example, if you have your first colonoscopy and you have three polyps and they are say X type of polyp and they didn't have any precancer, then I would probably recommend that you have a repeat colonoscopy in 3 years. If you come back in 3 years later, you have another colonoscopy and that colonoscopy is totally normal and you have no polyps that have grown, then you can probably start stretching back out to that 5 year and then 10 every 10 year, regimen. Um, if you have had 15 polyps on your first colonoscopy, or if you had polyps that had dysplasia, or if you had a big polyp that was, bigger than a grape or bigger than a walnut or something like that, then your provider's probably going to recommend that you have a colonoscopy in a year from then. And then I think everyone's taking more of an individualized approach, looking at what's your personal risk for having polyps come back and for having those polyps ever become cancerous and deciding when you should come back for another colonoscopy.
Okay. And can you talk about the difference between IBS and IBD, and where does Crohn's fall in the symptoms in connection to colon cancer?
Yeah. So IBS is irritable bowel syndrome. Very, very common. You can have IBS with primarily constipation, IBS with primarily diarrhea, IBS with a little bit of both. And that's really sort of not well understood, but purely sort of symptomatic syndrome of the colon where you just don't have sort of regular bowel movements. Um, Inflammatory bowel disease or IBD is different. If those patients have a truly chronic inflammatory disorder of the GI tract, which includes Crohn's, to that question, or ulcerative colitis, and then some other kind of miscellaneous colitis options. So, people that have an inflammatory bowel disorder or disease are, if it affects their colon, typically are at higher risk for colon and rectal cancer. The kind of cutoff is after you've had colitis, or inflammatory bowel disease for about 8 years, that's when your risk starts to increase. And so for those patients, if the colon's affected, they typically, I would recommend having a colonoscopy every 2 years for surveillance or for screening to make sure that you don't have any areas that start to have any dysplasia or precancer or cancer.
Okay. And again, if you find a regimen that's maybe over the counter that works for you, is it safe to carry on daily with that? So like Miralax, for instance, is it okay to use Miralax every day?
Yeah, I think I have see a lot of patients that really struggle with constipation. And so my first message would be not everyone has to poop every single day. Like it can be normal if you only poop every other day or every 3 days, as long as you feel okay and that's normal for you. Um, if you do require laxatives to get you to feeling like you're having regular for you bowel movements and you're feeling well, that's okay. There is a little bit of the catch-22 of at some point your body may get kind of too accustomed to that Miralax, so you may have to increase your dose, or eventually the Miralax doesn't work and you may have to switch off onto something else, or try to other like prescription medications that work a little bit stronger than some of the over-the-counter laxatives. But if you have found a regimen that works for you and you're having regular bowel movements, then it's perfectly okay in my book to continue that regimen.
Okay. And are there risks to having a colonoscopy? So one person is asking, can it thin the walls of the colon, or are there risks to actually cutting the colon or um, damaging it in any way during the colonoscopy?
Air or with liquid. And so there is a risk that we kind of distend the colon too much with air. There is a very, very, very low risk, but a risk that the colonoscope can put a hole into your colon, in which case typically is an emergency you need surgery for. Again, that's very, very, very low. Risk of bleeding, less so if we're not doing any procedures, but if you have a polyp removed, especially if you're on blood thinner medications or if you take blood thinner medications, there's some risk of bleeding after the colonoscopy from that site where we've removed that polyp. They're again, very, very low risk of like injuring other portions of the body other than, in other organs in the abdomen that sort of live near the colon. And then again, you're having a sedation medication, so it's not a full general anesthetic. You're not having the breathing tube put down your throat to help you breathe, but it is a little bit of medicine that sometimes can uh, cause your heart rate to be a little bit lower than normal or cause your blood pressure to be a little bit normal than when you are awake. So for that reason, the anesthesiologist or the nurses in the room, everyone's always monitoring you really closely.
And at the completion of the procedure, I imagine you're sent home with lots of information and what type of symptoms to look out for and to head to the emergency department if needed. Is that an accurate?
Yep.
Okay.
Yeah, so the nurses in the recovery area are always really good about going through your paperwork. Typically, you're going to get a report that day of what they found at your colonoscopy, and then signs and symptoms to look out for and things that you should be concerned about that would prompt you to have to go to the emergency department.
Okay. So someone had their first colonoscopy a few months back where two polyps were removed. They've noticed that their stool is more soft after the colonoscopy. Is that a cause of concern?
I wouldn't necessarily be concerned about it. If you're feeling otherwise well, then it may just be a coincidence. Unless they were very large polyps, they probably didn't impact the consistency of your stool. But maybe you're drinking more water now or being a little bit more cognizant about what the consistency of your stool is after the PTSD of doing the prep. Um, but I wouldn't worry too much about it.
Okay. And that's an interesting point about diet because there's so many things that are seasonal, like vegetables and fruits and things. So I'm sure that can change your stool like throughout the year.
Yeah, absolutely.
Interesting. Okay. Somebody is asking about the time frame for recovery after a robotic assisted bowel resection where 8 inches of bowel were removed. Do you have any thoughts on an expected recovery for something like that?
Yeah, I do think it matters like what portion of the bowel was removed. So colon, rectum, small bowel, I would say all maybe perhaps a little bit differently, but um, I would say on like everyone's a little different. On average, you're going to spend a night or a couple nights in the hospital. Eventually, we are going to start you back onto regular diet and wait for your bowels to start working normally for you to start having bowel movements and stuff like that. Because of the beauty of the robotic surgery is that your pain is hopefully pretty minimal. You don't have any big incisions, so your activity restrictions aren't quite as stringent as if you would have had a huge, long laparotomy incision. So I would say most people spend a few nights in the hospital, start to recover a little bit more quickly at home, and then probably within a few weeks or even a month out, are starting to feel back to their normal selves.
Okay. And is IBS typically diagnosed by your primary care physician, or is that something that you would see someone like yourself for?
Yeah, it can be. IBS is kind of one of those things that we have to like rule out all the other bad stuff first before we can truly say you have IBS. So I think a lot of people probably do have IBS. It's probably fine if your primary care doctor diagnoses you with IBS and helps you kind of navigate, treatment options. But if you do come to see a colorectal surgeon or an endoscopist or a general surgeon, probably we're going to recommend that we do a colonoscopy to make sure that you don't have an inflammatory bowel disease or some other, colitis or something like that, and then treat you, for the IBS afterward.
Hey, and what about colon infections like C. diff? If you have something like that, do you need to have more frequent colonoscopies? Or if you don't have
Typically,
symptoms? Okay, go ahead.
yeah, not typically. C. diff is so common now, that most of the time we just treat you with the right antibiotics, and then hopefully it goes away, and then it doesn't necessarily intrinsically increase your risk for colon and rectal cancer.
Okay. And are men more prone to colon cancer than women?
Not necessarily, no. The colon and rectum is, sort of the same organ in men and in women, so our risk is about the same.
Okay. I just have a handful more questions if you're okay hanging in there for a few more minutes.
Sure, yeah.
This person had a physician suggest that they do Botox during a colonoscopy. And when about to have the colonoscopy done, the doctor doing the colonoscopy disagreed with doing Botox. So I assume it's not like the typical Botox. I'm assuming within the colon itself. Is that right?
So the only thing that I would be familiar with is we will use Botox to treat an anal fissure. Um, I've never heard of someone doing them at the time of colonoscopy. I guess I don't know why you couldn't do it, but typically the Botox that we use to treat a fissure is more like either done in the office or done in the operating room, and separate from the colonoscopy.
Okay. Can grade 3 hemorrhoids go away? And is surgery for hemorrhoids a good idea?
Um, so grade 3 hemorrhoids, You can symptomatically make them better through a good bowel regimen and preventing any constipation, diarrhea, or extremes of bowels. Sometimes rubber banding may help as well. So grade 3 hemorrhoids means that you have internal hemorrhoids that have gotten larger over time and are able to prolapse out of your anus, typically when you have a bowel movement. And then you have to sort of manually push them back up inside the anus. Um, so rubber banding may be an option for that. Typically, though, once you've gotten to that stage of grade 3 or grade 4 hemorrhoids, your provider's usually starting to talk to you about hemorrhoid surgery. I recommend hemorrhoid surgery for patients that have maximized all other options. Um, so some of those, office-based procedures, diet, bowel regimen, stool softeners, steroid ointments, all the kind of options and tools and tricks that we have in our bag before surgery, because hemorrhoid surgery is very, very painful. It has a very long recovery. It's probably the most painful surgery I do. It's hands down more painful than colon cancer surgery. So I usually try to get people through anything that we can first before we talk about doing surgery.
Okay. And how long does it take for the effects of a colonoscopy to wear off? So this person's asking, can you be gassy even into like 6 months after colonoscopy? Is that possible?
Not usually. The only caveat I would say to that is I think we're realizing more that like the our gut flora is very sensitive, right? So everyone has little microbes that live inside our colon under normal circumstances, and perhaps the prep or the colonoscopy itself changes that a little bit. And so if you are having a diarrhea 6 months after your colonoscopy, my first go-to would be maybe you should try a probiotic or a fiber supplement or a yogurt like one of the Activia yogurts or something like that to help try to get your flora back to normal and see if you can get your bowel movements to go back to normal.
Okay. And can you explain what a small mouth diverticulum is? And in this case, it was found in the ascending colon.
Yeah, so those diverticula or diverticulum, like we talked about before, those little pockets on the side of the colon, they can actually they can appear anywhere in the colon. So the ascending colon is the colon on the right side, like kind of sitting just above your right hip. But they can be anywhere. The most common site for them is something called the sigmoid colon over on the left corner, on the left hip. And then small mouth just means that your endoscopist was kind of looking at the diverticula and deciding how big they were. So that yours was a little bit smaller. Sometimes they can be quite large. Sometimes you can have a lot of them. Sometimes you just have one. So you have diverticulosis, or you had a small diverticula in your right colon. And if you never have problems from it, then I wouldn't worry about it. And I would definitely not change anything about how you're eating. I wouldn't recommend you avoid seeds or anything like that. Just a good high fiber diet.
So you can rest assured that if you have something like that come back on your results, that your provider will talk you through next steps if there are next steps that need to happen.
Yeah, yeah. So, diverticular disease or diverticulosis is very, very common. Probably more than 50% or more than half of people over the age of 45 or 50 have some diverticula. Um, Part of that is genetic, part of that is like the kind of low fiber diet that we tend to eat over in the Western half of the world. But I think diverticulosis is so much more common than people think. But the majority of people don't actually ever have symptoms from diverticula. So just because your endoscopist found it on your colonoscopy does not mean that you need to change your diet, need to eat certain foods, or worry about having problems down the road. It's just that something that they found.
Okay. And I know a lot of times when, at least in my experience, taking relatives for colonoscopies, typically I get the information, but the patient themselves is usually a little bit sleepy. So if
Yeah.
later that day or when you get your results, you're reading it and you have questions, is it appropriate to shoot your provider a message or give them a call to try to clarify?
Yeah.
Okay.
Yeah, absolutely. So, if you did have biopsy results, then sometimes they should be, calling you to review that kind of stuff, and then you can ask them then. But absolutely, if you have questions, it's nice to wait until the anesthetic wears off and you're not sleepy so that you can remember it. And that anyone should be happy to talk to you about anything they found.
Awesome. And then there's one more question from a distance runner. So they're wondering, after a marathon or a long distance race, is it normal for a runner to have blood in their stool?
Um, well, I would say, never normal to have blood in your stool. I would suspect that long distance running probably has causes a little bit of dehydration. And that long-term kind of running and stress is probably not great for hemorrhoids. So it may just be that. But if that has happened a time or two, or if it's something that you're worried about, then you should probably talk to someone about a colonoscopy.
And follow-up question,
Hmm.
does having blood in your stool, so is there a way to tell kind of where the blood's coming from? So if it's like a really bright red and maybe it's on your toilet paper versus on the actual stool,
Yeah,
there are ways to tell, kind of when, like, you can probably feel if you have a hard stool and you have blood, you could probably
yeah.
feel that. But I'm just wondering, are there ways to tell when, the blood is coming from maybe more inside your colon versus on the outside or your anus?
Yeah, it can be very hard to tell. I would say, like, in general, just like you said, like, you can usually tell if you're having constipation or if you have hemorrhoids that are very tender around your anus. And you typically that kind of blood will be bright red. It may be on the toilet paper or sort of like on the streaks on the sides of the stool, but the stool itself will look normal. If it's coming from somewhere upstream in the colon, will more tend to be like mixed in with the stool, or even coming from further onto the right side of the colon, it can appear black or like coffee ground. Um, but it can be difficult to tell for sure. The take home being that really no amount of blood is ever really normal.
Okay, and this person is asking, is it normal to have like any other kinds of discharge after a bowel movement?
Um, so like some amount of like mucus can be normal. Um, I guess I'm not really sure what other kind of discharge, but I think if it's anything that's a change for you, so if you used to be totally normal and then all of a sudden you're noticing all this mucousy discharge, or you're having like bloody diarrhea or something, then your provider may want to check at your hemorrhoids or maybe think about irritable bowel syndrome or an inflammatory bowel disease or something like that. Um, I think the take home being like any changes you should keep an eye out for and ask maybe to be seen by a specialist.
Okay. And there are still some questions about age and whether or not there's a higher risk of perforation when you're older. But it really sounds like you said you should really make that decision with your provider. Um,
Yeah. Yeah,
okay.
I do hear that a lot actually. That I'll see patients and they'll say like, "Oh no, my primary care doctor said I'm too old. It's too dangerous for me to have a colonoscopy." And I don't necessarily know that there's certainly like, that hard stop age cutoff where the risk is higher.
Okay. There are several comments in here about how easy this talk was to understand. So, and I totally agree with that. You did a wonderful job, Dr. James. So
Thank
thank
you.
you so much. This is Colorectal Cancer Awareness Month. So I'm so happy you were here to spread some awareness and
Yeah.
answer all these questions.
I love talking about colon rectal cancer. I love my job, and I think it's so important to talk about. So, and I'm really glad that you guys had me.
Of course.